All righty, it is 2:30 and I have lots of slides to get through and I am totally excited about questions. So I'm going to go ahead and get started. So if you guys have questions, I am going to keep the chat up. So if you have, let me make sure that I have those on so that if you have any questions, please feel free to pop it in the chat. We're talking about one of my favorite things to talk about. Cardiovascular disease is one of my fears, not only with myself and my family members, but also with my patients. And so I have, in the last, I'd say, probably 8 years, really delved into learning as much as I can about cardiovascular disease and heart health. So we're going to start and dive into this talk. So to start, I wanted to actually bring up the thought about the heart. It's actually one of, I think, the more complicated things in our bodies because there's so many pieces to it. So I want you to think about the heart first in terms of what does it do in the body. So think of it as a pump. The heart is a pump. And it's connected to the vessels that serve our body. But what it's doing, this system here, the heart has these vessels that go to the lungs, grab oxygen, go back to the heart, and then they pump from the heart to the rest of the body. So the point of the heart is to go to the lungs, grab oxygen, go back to the heart, go to the larger of the pump, and then go out to the rest of the body. So this picture really shows we've got our right heart and our left heart and where the blood goes. And it's not important that you know the order that the blood goes through, but thinking about these vessels as like a closed piping system that has a pump in it. Technically, there's two pumps. The right heart is one pump, and the right heart pumps out to our lungs, and then it goes from our lungs back to our left heart, and from our left heart it pumps and then goes to the entire body, and it fuels every single cell in the body, which I just think is amazing. And all of those vessels, the arteries are what we call the vessels that go away from the heart out to wherever they're going, and then the vessels that go from either the lungs or the body back to the heart, those are called veins. That's the difference between an artery and a vein. So the heart is essentially a dual pump, pumping out to the lungs, grab oxygen, back to the heart, and then out to the body, and then back to the heart. So think of the heart as a pump or a dual pump with all these pipes, and those pipes are really a closed system. Now, the pipes can dilate or constrict, and that allows this closed system to deal with changes in pressure, right? I kind of think of this as like a plumber, like this is a plumbing system. So that's the heart as a pump. And then the other part of the heart is that the heart is an electrical circuit. You can see here, this is called the SA node, and this is an electrical part to the heart. What's super cool about this part of the heart, I remember learning in medical school, was if you take cells from a heart that are from this part of the heart, this SA node, if you take cells from that part of the heart and you put them in a petri dish and you put a little bit of an electrical signal on those cells, on the tissue will contract on its own. The cells have an innate, what they do is they send an electrical signal. They send an electrical signal. And when they send that signal, it stimulates the muscles to contract. So the way that the signal works is the SA node sends a signal and the top of the heart contracts first. And then it puts the blood from the top of the heart into the bottom of the heart. And then this node contracts, it sends a signal to the bottom of the heart and to squeeze upward and to eject the blood from the bottom chambers out to the body or to the lungs. I'm not a cardiologist, but man, this part of the body is, talk about wisdom. So the heart has all these pieces that it does. So keeping that in mind when we go through, right now we're going to talk about cardiovascular disease, which means we're primarily talking about the heart as a pump. We're not going to talk about the conductivity or the electrical components of the heart at all. So when we think about cardiovascular disease, the reason I have this picture is that the heart and the brain are very similar organs in this sense, because they both have the small vessels. So not only do we want to think of the heart as a pump, but we also need to think of the heart is a muscle, and in order for the muscle to work, the muscle also needs oxygen, which means the heart has to have vessels on itself that feed the muscle itself, that tell the muscle to have enough oxygen and do its job. When we think about heart attack or stroke, that problem is happening in the small vessels. So small vessel disease is going to both affect the heart and the brain. Now, we have small vessels everywhere. We have them in all of our skin. So if we cut ourselves, that's what we're cutting, is we're cutting those small vessels. The problem is that if you cut your arm, you're not going to die. Whereas if you were to cut a vessel in the brain, and now the tissue that vessel was serving in the brain is not getting oxygen because that vessel is now no longer bringing oxygen to that tissue, then the tissue dies. So the reason we care about small vessels is that they're most important for vital function in the heart and in the brain. So that concept, I think, is kind of cool. Cardiovascular disease. So here we're talking about myocardial ischemia. This is where ischemia is where the tissue is no longer getting the oxygen that it needs because the vessel that is going to that tissue is occluded. So this is a healthy blood vessel with blood flowing through those vessels. And these vessels, you can see, are on the outside of the heart, serving the muscle of the heart. And then this is an example of a blocked. Now, the word coronary just means heart. So your coronary arteries are the arteries that are on the outside of the heart that then go into the muscle of the heart. So coronary artery disease is disease of the vessels serving the heart. Here's another picture that kind of talks about, thinking now we're kind of coming down to a microscopic level. This is a vein. These gray things are the lining of the vessel, and there's this whole process that's happening inside the vessel. So I almost like to think of this as like a landscape where there's a river and there's an environment around the river, and what's the floor of the river like, and what kinds of things are going into the river and leaving the river, and what's the pressure in the river? Is it a narrow part of the river and the water is flushing really, really quickly? So this picture here kind of shows you the things that are happening inside our blood vessels. There's a process that happens with the red blood cells, the LDLs, and the cholesterol all inside the vessel, which I'm not necessarily going to go through. I want to make this talk much more user-friendly. Here's another picture that shows the difference between the inside of a vessel where we have plaque. Okay, perfect. I'm glad you can hear me. So we have plaque on the inside of the vessels. This is the lumen of the vessel, which is basically like the canal where the blood's going to flow through. And then over time, these plaques can rupture. There's also a concept where these plaques are either stable, where sometimes they're stable. Like this picture here, you can see this plaque is fairly stable, meaning it's not going to rupture. Whereas if there's inflammation or high blood sugar that's causing inflammation in the lining of the vessel right here, that plaque is more susceptible to rupturing. And in that case, it would cause a clot. Same thing in the brain. When we have a clot in the brain, we're going to have a problem. Now, in the brain, we have two types of strokes. We have an ischemic stroke, which is what we call when there's a clot, and we have a hemorrhagic stroke, which is what we call the vessel when there's a vessel damage and it actually breaks off and bleeds outside of the vessel. Now, the risk factors that are affecting cardiovascular disease, there's so many of them. I'm not going to talk about all of them today. I want to talk about kind of, I think, the most important ones. But smoking, blood sugar, physical activity, body weight, cholesterol, blood pressure. We're not even talking about blood pressure today. I'll certainly have some clinical connections to it, but we're not going to talk a lot about it. Genetics, gender, age, race, and ethnicity. Obviously, there's so many factors that affect us. So let's dig in. This is what I call my triad. And many of you who may be my patients, you've probably seen me draw this out on a sheet of paper. But I think of these three components kind of like legs to a stool. And you have to have enough legs. You have to have at least 2 out of 3 of the legs for it to really actually affect your risk. So when I'm assessing, are you at risk for cardiovascular disease? I will check in on, well, what are your sugar markers? What are your inflammation markers? And what are your cholesterol markers? So let's go through. We're going to go through the sugar markers. Now, you're probably familiar with some of these sugar concepts, but our body, we eat sugar in our diet in the form of carbohydrates, and all carbohydrates, I want to point out, eventually get broken down into sugar. So whether it's ice cream or broccoli, it is still going to get broken down into a carbohydrate. Once we have enough sugar, the sugar stimulates the pancreas to secrete insulin. Insulin is the key that unlocks the door so that the door can open, and then glucose goes inside of the cell, and then inside the cell it will get burned as ATP, and then you have energy. So I'm checking for this because I want to know, has their diet been too high in sugar or carbohydrates? Because sugar is sticky, and sugar will stick to the lining of the blood vessel. And the stickier the lining of the blood vessel, when you have a cholesterol particle come traveling down the blood vessel, if you have a sticky lining, that cholesterol particle is more likely to get stuck on the side, the wall of the vessel. And that right there is the beginning of a plaque. So here are our blood sugar chart. We've looked at fasting blood sugar. Normally they say we want it between 80 and 100. I will tell you my goal is I want a morning fasting blood sugar, really ideally less than 95. Now, if you're wearing a continuous glucose monitor or you're checking your blood sugar after eating, about 2 hours after eating, you really want it to be back down to about a 120. 130. If you're still in the 140, 160 2 hours after eating, that's impaired glucose management. Another way of measuring for blood sugar is to look at hemoglobin A1C. This is the average blood sugar over the prior 3 months. And here are the reference ranges. Now, conventionally, they say that you're pre-diabetic once you are between a 5.7 and a 6.4. I personally want my patients less than a 5.6, 5.5, and really ideally less than a 5.4. So if you want to make a note, hemoglobin A1C optimally should be less than a 5.4. 5.7 to 6.4 is technically pre-diabetic, and greater than a 6.4 is diabetic. So this person here was a 5.4. I'm going to skip this slide. This is basically explaining how hemoglobin A1C, it's giving us an average of our blood sugar over the prior 3 months. And that's what these are. Insulin. So this is another one of my favorite markers to measure for blood sugar regulation. So conventionally, they want this less than 24. And if you remember back to the picture, sugar stimulates the pancreas to secrete insulin. Insulin is the key that unlocks the door. Now, if the person has been eating too many carbohydrates over too long of a period of time and their body has been over-sugared, then the pancreas has been pumping out insulin all the time to get rid of that sugar. And the problem is that the more insulin you have, the more the key becomes denatured. Your insulin becomes faulty. The insulin key now no longer works. Think of a key going into a lock, and what happens is the receptor becomes, you could think of it as the receptor becomes numb. It's like insulin's been banging on the receptor for so many times that now the insulin receptor is not working. So now when insulin binds to the receptor, it's resistant, and we call this insulin resistance. which is exactly the same thing as prediabetes. So what does the body do? It makes a whole bunch more insulin. We got to get that sugar down. We got to get that sugar down. And that's exactly what you see here. You see high insulin. So a elevated fasting insulin, I prefer it less than 12. Conventionally, they say less than 24. It should be less than 12. And some say optimally, it even should be less than 9. So this person here is overtly insulin resistant pre-diabetic. So moving on in the triad, we talked about the sugar markers. Now we'll talk about inflammation markers. Here's a nice picture that talks about these inflammatory markers. You probably are familiar with this one, high sensitivity CRP. This is an inflammatory marker that I measure in anyone over 30. I will measure this marker. And if this marker is high, I like to kind of go the extra step and look at additional markers. So oxidized LDL is one of my favorite markers. The F2 isoprostanes is a good marker. Sometimes I'll measure this one here, myeloperoxidase. And this one here, the LPPLA2, this is an important marker because this one's telling you about how stable any plaques are. You want them to be stable. An unstable plaque is more likely to rupture. So this is a helpful picture. Here's just to touch on CRP. So we want our CRP less than 1. If it's in the 1 to 3 range, we're dealing with potential risk. Now I will make a quick comment here. There are multiple reasons why CRP high sensitivity can be elevated. So if this is elevated, don't freak out. Just know this is kind of a screening test, but other reasons this could be elevated was if the person had a recent cold or flu, a virus, a recent alcohol party. Sometimes even women on their period, you can get this elevated. I've had this be elevated post-vaccine. So if it is elevated, you want to then move forward and test for additional cardiovascular inflammatory markers and find out, is this true cardiovascular inflammation or was the CRP skewed? Please interrupt me if you have any questions. These here are 2 advanced inflammatory markers. Right now I'm using a company called Boston Heart, and any of the doctors at Living Wellness are familiar with these tests. So if I'm not your provider, talk to them about ordering these tests. But the LPPLA2, this indicates vascular inflammation and plaque instability. So this is an example of one of my patients where this number was quite high. And when numbers are high like this, what it's doing is it's giving me a little more information that helps me make a clinical decision. How aggressive do I need to be at trying to lower cholesterol, lower blood sugar, lower inflammation? Because this scared me. Another one is this oxidized LDL. So oxidized LDL, you probably remember the concept of aging. Aging is the process of oxidation. We are always aging and our cells are always being oxidized. We're oxidized by the air, we're oxidized by environmental toxins, even the air, part of just the process of our body living, there's this oxidation happening. And the more oxidation that's happening, the more advanced the aging process is happening, which means we're oxidizing our cholesterol. So this oxidized LDL occurs when oxidative stress causes changes to the LDL. And this is a key factor in the hardening of the arteries. So this is telling me how many artery issues, it tells me about the health of the vessel wall. Moving on to the next part of the triad is cholesterol. Now you're familiar already with the good HDL, the bad LDL, and kind of the bad triglycerides. Now the problem with the conventional lipid panel is that the conventional lipid panel just doesn't, it only tells us the number of particles. It doesn't tell us anything about the size of the particles. So for example, this LDL, we actually have multiple LDLs. So I tell people we have the LDL, we have the smalls, the mediums, and the larges. And the smalls are actually the problematic LDL. Same thing with HDL. We actually have smaller ones and we have larger ones, and it's the larger ones that are more protective. So the problem with our conventional lipid panel is that it only is telling us how many of each of these HDL and LDLs. It's not telling us how many of the different sized molecules. So I like to do a test that does break that down. This is a test, and you can do this through LabCorp or SonoraQuest, where I'm able to measure, let me whiteboard this again, I'm able to measure the small LDLs. The small LDLs are the problematic bad guys. And you can see we want them less than 520, even 550 is fine. And this person's was up in the 1900s. Now I've seen this even above 3000, which that was obviously a more aggressive, scarier. I'm going to be more aggressive, probably going to be recommending pharmaceuticals to lower their cholesterol. But this helps me make clinical decisions, is to do this test where we're looking at the actual size of the particles. Here's another picture that kind of gives you this concept. The larger particles are not so dangerous. And the way I think about this is these are the large, buoyant beach balls bouncing down the blood vessel. And when they hit the lining of the blood vessel, when they hit the wall, they just keep on bouncing. They're so big and buoyant and they just keep bouncing. Whereas these little, small, dense, round golf balls, these are dense. And when they go bouncing down the vessel of the blood and they hit the lining of the vessel, when they hit the lining of the blood vessel, they're more likely to get stuck, especially if the lining of the blood vessel that they're touching is sticky from sugar or inflamed, because now the lining of that blood vessel is just waiting to stick onto something, and that's the beginning of a clot. So a few more concepts that affect all of this health is calcification. There's this continual flow of calcium that's bouncing between our bones into our blood. And just an example of this is when we eat food that makes our body a little bit more acidic, the body doesn't like to be acidic. So the body is going to do something about it. So the body is going to suck calcium out of the bone and put it in the blood to buffer the acidic blood. Now, the problem with that is it adds more calcium to the vessel that then can increase calcification of the vessel. And not only that, but it also sucks out calcium from the bone. So my menopausal women are more at risk for osteoporosis or osteopenia. So this concept of calcification is kind of important to know. This has to do with the heart. So the way I approach this is check vitamin D, because if you don't have enough vitamin D, then you're not going to be putting that calcium back into the bone. Same thing, check a bone density. A bone density is going to tell us if you have enough vitamin D and vitamin K. You can measure vitamin D on labs, so optimize your vitamin D levels. And I didn't put a slide in here about that, but my reference range is 60 to 90. So if the person is lower than 60, I would add some vitamin D. You can't really efficiently, or you can't really accurately measure vitamin K. There's some micronutrient tests that will, but I'm suspicious that it's telling me what I need to know. I'd rather do a bone density, and if their bone density is on the lower end, they need vitamin K. And dosages are very specific with vitamin K. So that's something you'd want to talk to your doctor about. And I'm not going to recommend a specific dose on that because it's dependent on the person, and you want to make sure that they're not on blood thinners if you're going to give them that form of vitamin K. But this concept of calcification is important. Taking that idea of calcification a step further, you could do what's called a calcium score test. And the calcium score test tells us how much calcification has happened in the vessels. And here's kind of the range to be aware of. Anywhere from 0 to 100 is kind of low risk to mild risk. And in the 100 to 400, that's now starting to show risk. And then obviously the higher the number, the more calcification there is. Now, I mentioned that when you eat acidic food, it's going to pull calcium out of the bone, put it in the blood to calcify, to buffer our acidic blood. This is just a picture of the acid-base food balance. You know, you've probably heard of, eat an alkaline diet, eat an alkaline diet. This is why it's important. Cancer tends to grow in more of an acidic environment. Immune systems tend to be weaker in an acidic environment. So this is why we're always told eat more fruits and vegetables. If you go to online and you Google Alkaline Sisters food chart, they have a wonderful website with great recipes, but they also have a really cool downloadable food chart. And it actually gives you the pH of like 100 foods. And one of them I just had memorized on there was watercress. If you were to juice water, so this is why juicing is so good. Because when you juice, and you need to be careful of sugar content in the juice. So, but that's another side note. To me, the juice is still valuable enough that it's worth doing. When you juice greens, it is super condensed alkaline. I mean, juicing and getting in alkaline foods is one of the most effective ways of reversing and preventing chronic disease. There's lots of book on this, alkaline diet, the pH diet. The pH is this scale here. So I will let you research that further. So what is it that we need to do? We need to just be aware of how do we support our heart and our brain. And I also think it's important to remember that our nervous systems also affect the health of our heart and our brain. And so doing things that help to support the parasympathetic nervous system. Our sympathetic is run, go, do, run your business, manifest, be busy, create. And parasympathetic is more about reflect, calm, digest, heal, regenerate, antioxidize, and slow the aging process. I had another talk, if you check out our YouTube channel on, I think the talk is called How to Parasympathize. And I go through a whole list. I go through a list of about 20 things you can do to support your nervous system and stimulate the vagus nerve, which is our primary parasympathetic nerve. So I just bring this in there because this does help alkalize the body. It helps to balance out the hormones that's going to help the heart. So things we can do. Alkaline diet, anti-inflammatory. Michael Pollan's book you've probably read. I think it's, I'm trying to recall the actual name of his book. I cannot recall the name of the actual book, but the quote from his book that I just love is eat food, not too much, mostly plants. Here's our Living Wellness Food Period, which is basically a Mediterranean diet. And I know this is way too small to read, but the majority of what we should eat on our plate should be our vegetables, followed by protein, then followed by our micronutrient-dense fruits, then followed by grains, minimal dairy, minimal sweets. Here are some supplements, and if you want to take a screenshot of this page or a photo, feel free. I did put some dosages up here. CoQ10, super important. This helps with ATP production. This helps with energy. Fish oil. Now, this is a pearl I do want you to get. Everyone knows fish oil is good for the heart, but what we're not paying attention to is how much EPA and DHA there is in it. So your homework is to go to your fridge, look at your fish oil, look on the back of the bottle, look at the serving size. It's probably one cap or two. And then look how much EPA is in 2 caps or how much EPA is in 1 cap, plus how much DHA is there, and figure it out. So if there's 500 of EPA, and oh my goodness, I have a total typo on this page. This is supposed to be 2,000 to 3,000. I'm so bummed I have that typo because this was my point. I'm so sorry. Well, parasympathize and we're all human, right? So this should be 2,000 milligrams to 3,000 milligrams of EPA plus DHA. So look on the back of your bottle, add up how much EPA with the DHA. When you add those numbers together, it should be between 2,000 and 3,000 milligrams. Now, customize that with your doctor if you're on blood thinners, because that potentially could thin your blood further. Fiber. This is going to help lower your cholesterol. If you go to our website and look at our free resources, we have a handout on fiber. It gives you a bunch of information. And you can even just Google how to get 30 grams of fiber in a day, and you'll get some really good ideas. Avocados are high in fiber. I sprinkle nuts and seeds on anything that is a savory dish that I can add some nuts and seeds to because they're so high in fiber. Vitamin B5 is good for cholesterol. Aged garlic, berberine, and artichoke, also good. Quick note on nitric oxide, and I hope you're all okay on time. I'm probably going to go about another 5 minutes. So nitric oxide, this is a cool messenger. This is a molecule that tells your vessels to vasodilate. And what it specifically does is it helps make your vessels stretchy again. It actually heals the lining of the vessel and it makes it young again. So it reduces oxidative damage in the lining of the vessel. It helps that vessel be more stretchy. So if you think back to the heart being like a pump, every time that heart pumps, the blood everywhere is going to feel the pressure. And if the vessels don't stretch, that is what we call hypertension. We want the vessels to stretch. Younger vessels are healthier and stretchier, like a rubber band. If you think about an old rubber band, when you stretch that thing, it's not going to stretch, it's going to crack. So nitric oxide relaxes smooth muscle. It helps with vasodilation. It's going to promote a healthy inflammatory response. These are some of the things that you can use to make nitric oxide. Now, many times I used to just give patients arginine. Arginine is an amino acid that the body then uses to turn into nitric oxide. Aged black garlic will support it. Beetroot will support it. Potassium citrulline. There's a couple of other herbs that will support it. And now there's actually a number of products that have combinations of these that help to support nitric oxide. So this has become one of my favorite things to include. And just recently, one of my favorite companies, Designs for Health, they just came out with these test strips. These are 3-minute saliva tests that you can do. And so I've just ordered these and I'm going to start doing these with my patients and showing them how you can measure your nitric oxide in your saliva. You take the nitric oxide supplement and 2 hours later you retest your nitric oxide and it is noticeably better. And the more time of your life that your nitric oxide levels are higher, the more time you're regenerating healthy vessel integrity. So there we go. There is my very quick 30-minute jam talk, giving you guys an overview of the cardiovascular. Do you guys have any questions? I'm going to assume that you don't, but I am going to wait 1 more minute in case you do. This will be recorded, so you'll have access to it. You're very welcome, Anne. Thank you for coming. Awesome. Well, I hope you guys learned something and took this away. I love it when people understand health, because then they're really more motivated to make the changes that I know that we're constantly talking to people about making. So now you understand why the alkaline diet is helpful. So take care, everyone. Well wishes to you all and enjoy this beautiful weather. Take care.